There are times during surgery when you discover a way to make things easier or more efficient. Sometimes there are through our own quicksand moments. Others are surgical gems gifted to us by our mentors and peers. This is OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu, where we learn how to pivot, reflect, and evolve as surgeons.
Welcome, everyone, to this episode of Ophthalmology Quicksand Chronicles Eureka Moments. We're your hosts. I'm Dr. Nicole Fram.
Hi, I'm Elizabeth Yu, and we are so excited to continue with season 4, Eureka Moments. Can you believe it's season 4,
I
Nicole?
know, it feels like it was
I
just yesterday.
I know, with little babies. Well, we're still focusing on those moments where we're taking away from the quicksand cases and all those things that we have learned from those surgical gems and pearls. And we're coming out of the dark.
Right. So there's always a point in surgery when you just want to leave. It's just too much. And we were in Ophthalmology Quicksand Chronicles before. That was what it was all about. You're looking at the clock. You just want to get out of there. Now we found a way with Eureka Moments to make your life easier. So you can anticipate these moments and never even have to go through it and skip that learning curve. Now, these pearls and gems have been gifted to us by our mentors and our peers.
And some of them are just through experiences ourselves where we realize, you know what? Through our own quicksand moments where we leave the OR and we're like, I just want to curl up in fetal position or have a big tall glass of wine for dinner. We've all been there. Nicole, haven't you been there?
I don't drink wine, just vodka.
Okay, so vodka, that's actually a great option too. But we have those moments, and for, those who don't drink, whatever it may be, just to escape the reality of what could have happened or what did happen that day. But you realize you expand your A to Z kind of armamentarium, and you can see the subtle movements or the subtle things that, this is what I'll do to prevent X, Y, and Z from happening. So these kind of techniques have certainly helped create, and we have thus want to share these eureka moments, those figurative plans A through Z that implement depending on what those situations call for. And we have all these great surgeons who all collectively have all of these eureka moments from their own either personal quicksand or from others' gems that have been gifted to them.
So, as a reminder, this season will be available through video and audio podcasts, so you can listen on your favorite platform or watch it on YouTube. At the end of the podcast, we would love for you to fill out a short survey. We can take it. We want constructive criticism. We want the good stuff too. And in the description below, you can help us understand what you found valuable so we can continue to make the podcast educational to all of our viewers.
So, Nicole, drum roll. Who is our amazing guest extraordinaire today?
We would like to introduce our guest today, Dr. Sumitra Khandelwal. Dr. Khandelwal is an ophthalmologist in Houston, Texas, and is affiliated with multiple hospitals. She's a professor of ophthalmology at Baylor College of Medicine Cullen Eye Institute and serves as the medical director of the Lions Eye Bank of Texas. Her clinical expertise includes cornea, cataract, and refractive surgery, and she serves on numerous committees with several ophthalmic associations. Now, I just had the pleasure of spending a week with Dr. Khandelwal in India at Amar Agrawal and Ashwin Agrawal's meeting. And we bonded like you wouldn't believe. I've known Sumitra for a very long time, as Liz has, but when you travel to India with someone and you have paper dosa together, there is nothing that separates you from that point on. So, Sumitra, I miss you every day, and I'm so happy to see your face and for you to share this incredible eureka moment with us.
That's incredible. And it's really funny how, things come full circle. So when I was on faculty at Baylor and as our family started to get bigger and we moved closer to be with family, and I'm currently in private practice in Virginia, Sumitra came on board to be a faculty at Baylor. So there was only, a very few days where our paths may have crossed while we were at Baylor, but certainly she has just lit, quite a torch and done amazing amazing things as full professor at Baylor. So we are so lucky to have Sumitra today. And this podcast is all about how we discover a way to make things easier or more efficient as surgeons. So, Sumitra, please take it away to share your Eureka moments.
Well, thanks so much for inviting me here. It's always fun to hear Liz and Nicole banter back and forth, and I'm just so honored to be here with both of you ladies. I teach at the academic center, and so in order to have Eureka moments, you really have to be in the sand, the quicksand, quite a bit. And so there's a special thanks out there for all my residents and fellows who allow me to become a better surgeon, because the moments that I have learned so much better in my own practice have actually been from working with them. You get in a little bit of trouble, but you can always seem to get your way out of it. So with that, I'm going to present a few cases actually, and really my focus is looking at iris, pupil pearls. The pupil is a wonderful organ. The iris can be your friend or your foe. And sometimes it can be very overwhelming when you see a patient and you're like, how do I conquer all of these iris challenges? So I'm going to share a few pearls by going over some cases that looked overwhelming, but we were able to kind of stepwise get through it. So I'm going to set the scene for a patient who actually was a uveitic patient. And at this point, they were very well controlled. They had been quiet for several months, 6 months. They had been immunosuppressed with the help of rheumatology. But the patient had a few interesting things about their clinical exam. They really had no pupil. The iris had synequed so much that there was no visualization, and the pupil was actually peaked towards a glaucoma tube shunt. Now, I know the glaucoma tube shunt had been there previous, and at some point it had been in a pretty good position, but because of all of the kind of anterior synechiae, because of all of the iris coming towards that area, not only was there really not much of a pupil, but the whole iris was sort of dragged towards that area where the tube shunt is. And I always say that if there's hardware and there's things going towards it, then you're not quite sure exactly what the order was. And so I couldn't decide where this pupil had created so many issues. So I kind of went in thinking that every single aspect of this case could have a little bit of a surprise. And so, the first thing for any case like this, I always say, is to make a couple of paracentesis. That's like the least stressful part of the exam, usually, of the actual surgery, usually. So I'm going to make a few paracentesis. I go ahead and make my first couple the normal way, although you can always redirect the paracentesis towards the area. And then I'm going to start to fill the anterior chamber. It is so nice when you can start breaking a little bit of that synechiae with the cannula of the viscoelastic. And I find a tiny opening right where the glaucoma tube shunt and the iris are kind of adherent there. But I'm going to go really slowly for a couple of reasons. One, I'm not really sure what's underneath that pupil. But also, I have definitely been in the situation where I sort of overfilled the anterior chamber. And I think if anyone's ever been in that situation where in order to conquer iris issues, they filled the anterior chamber and the areas of iris with more and more dispersive viscoelastic and even with a cohesive. And then all of a sudden the pressure is like 50 in the eye, in the anterior chamber, and you didn't even realize it. And then suddenly iris starts coming out of other areas like your paracentesis. So throughout this, I've learned from my old mistakes. I'm going to consistently kind of check my pressure through all of this. So my first pearl is don't overfill the anterior chamber. And so I always keep an eye on the pressure. And if it seems like the anterior chamber has too much viscoelastic, I'll burp some before I put some in, and try really hard to use cohesive if you can, because that's a little easier to burp out than a dispersive. And so, my next step here, because I've learned this from the past, not to overfill the chamber, I've got this big area of viscoelastic coming out of the paracentesis that I'm using. And so I'm going to use my other paracentesis to burp out some of that viscoelastic and check the pressure. And now it's time for me to say, okay, what are my next steps? That synechiae is in a really awkward place from my original two paracentesis. So I'm actually going to make some additional paracentesis that are like at 0 and 90 degrees in order to break the synechiae. And now I'm starting to realize that there's something underneath that synechiae, which is there's certainly a cataract, but I don't have a lot of zonules underneath that cataract as well. So I'm going to keep my eye on that. But that's kind of my next pearls, is that paracentesis are free. You know, they're small incisions. You usually don't have to suture them. If you find that your paracentesis is really, really, really awkward, and it's not helping you, then it's okay to make another one. It's okay to also angle them towards the area that you want to work with. And, you know, of course, you've got some real estate issues. You've got your wound and stuff to think about later on. But in general, you can make quite a number, and then you can use the paras for other reasons too. The other thing is to kind of keep your eye on the goal. Like my goal for this case, and I'll go back a slide, is to get this cataract out. And I don't need the pupil to be 9 millimeters to get this cataract out. And what I'm noticing here with my cannula is that glaucoma tube shunt is actually adherent to the anterior capsule in that area. That's very different than what I was anticipating. I thought the glaucoma tube shunt would be really adherent to the iris. But now that I've realized that, it is so tempting to say, okay, let me go in, let me fix where that tube shunt is located, but that's not my goal today. That can be a glaucoma job on a different day. My goal is to stay in the center of this lens because I don't need that periphery to take out this cataract. I just need a nice central anterior capsulotomy, and I can let that tube shunt hold that, you know, cataract in place if that's what it desires to do. So make sure in these cases, it's so nice to be heroic and do everything. But here, I'm just going to walk away from that whole little region of the eye and let that be something to conquer on a different day. This next, I'm going to say, okay, here I have this case, and the pupil, I mean, it started out basically 0, and now I have expanded it to like 3 millimeters, but very eccentric. The central part of the actual iris is still not really visualized. And so I'm going to stretch it a little bit, but this is not a great case, in my opinion, for a malunion ring. This case is much better served with iris hooks. And basically the thing about iris hooks, I'm going to pause for a second, is that we have this thinking when we're training the residents that we want them to be really efficient. And we certainly start them out with malunion rings because they're so easy to use. But I find in cases like this, iris hooks can be so efficient. And so I'll go over my way of doing iris hooks. People do them all differently. But I find that if you make your paracentesis first and then put your iris hooks in place, but don't necessarily hook the iris yet, just get it into the anterior chamber and then come back around and tighten them. That can be a nice way of using it. And I'm usually by myself actually for some of these cases. And so I can hold the iris hook box with my left hand, and with one hand just put these in each of those paracentesis so that I'm not in danger of losing one of the paras. Or sometimes, you know, as you get older and wiser, you can't see the iris hooks very well either. And so this is just a nice way to get it in there and then put in the iris hooks. For iris, I make my paras first with the for the iris hooks, and then with one tying forceps, I put in the iris hooks just into the anterior chamber, and I put 4 in. It's always nice when you're first starting out. If you're not sure where your wound's going to be, you can always kind of mark where you're going to do them, so you don't use some real estate that you want later on. Now I'm going to slowly tighten them all the way around. I don't want to just tighten them right away because then that makes my next iris hook really hard to put in. And look at that, I put a 5th iris hook in. You know, I once joked around with one of the residents, why do you think there are 5 iris hooks? And they answered, in case you drop one. Which is always nice, you know, to have that 5th one. But the reality is 4 iris hooks in these complex cases, at least for me, are almost never enough. And so in this case, yes, I had a nice little diamond, but because that iris doesn't have that same quality, it didn't stretch enough, at least for me. And with this case, with all the possible zonulopathy that I'm already seeing under the tube shunt, I wanted to really visualize as much as I can. So I added that 5th hook, and that's my next pearl. Is just don't forget that 5th hook. It's there for you. And if you don't like how the first 4 look, and then, you know, don't forget, you can always open up another iris hook set too. And so keep that in mind because paras are free, and iris hooks aren't free, but they are far less expensive than some of the other things we use for complex cataract surgery. And so, at this point, though, I would say the rest of this case went fairly smooth, which was really nice. It was just that one area of zonulopathy. And I know Eureka moments are probably abound about how to fix zonulopathy or conquer it. But for this case, actually, I do think that tube shunt was kind of holding that in place. And I think the rest of the zonules were pretty good, which is wonderful. I will say this is how I take out iris hooks. I just kind of go in and I pull them out. And I just kind of keep them in the fornix. I don't put them each back. I'm sure my scrub tech loves it, but I'll let them be the ones to count them off and all of that. Because once again, when you're by yourself, that time spent putting it in each of those little individual parts of the box can take a little longer. And I think that's why people don't like to use iris hooks. It does take a little longer, but it can be a very cost-effective thing. And then I'm just going to give all of those. And then, this kind of goes back to the original one. I finished off this case, went pretty well, all relative speaking. That iris is not perfect. It's now about a 5 to 6 millimeter iris, but it still has that defect right where the glaucoma tube shunt is. And, I would love to say that I could go in and do a full 4-pass pupilloplasty the way the Agarwals have taught us. But I'm not going to do that today. There's a glaucoma tube shunt. It's against the anterior capsule. I'm hoping one day glaucoma will fix it. Maybe they won't. But I'm not going to put in a pupilloplasty for this case. I actually wasn't 100% sure what her visual potential was either. And so we're going to leave this for today. We're going to keep our eye on the goal, which is taking out the cataract, which I did, and then let, glaucoma maybe come in later if they want to move that tube shunt, or if they want to help me with doing something where I can put that iris back together again. And I will say, a lot of these pearls from a case like this can transition even to cases that maybe aren't so complicated. Maybe that case I described is not something that you would have in your own practice, but sometimes we get into a little bit of trouble just with kind of standard cataracts. So this is from one of our training centers, but this can happen to anyone and has happened to everyone, where basically it's a dense lens and a little smaller anterior capsulotomy, and going in to do the hydrodissection, not only does fluid go around, but iris starts to come out of the main wound, as you see there. And, taking the cannula out here, I mean, this is very early in the case to already be having iris prolapse. And so, we talked a little bit about that 5th hook. One little trick to do is, first off, you really want to get that iris back. You don't do that. This was, you want to pull that iris back, but you don't want to go through the iris with the cannula. You want to really use your paracentesis to sweep that iris in. For this case, what they did is put a little side port, a little paracentesis, just about 1 millimeter posterior to that main wound, and then put one of the iris hooks actually, and just pull that iris out of the entryway of the wound so that it's actually a little further back. This way, for the rest of the case, as the resident's going in and out, that iris is out of the way. And so, once again, a case like this could be really challenging if that iris keeps coming out each time you go in and out. And I even had cases where the iris was very floppy, and I put, a Malyugin ring in, and then I was like, well, I don't know about this. Even with the Malyugin ring, some of these cases, if they have really floppy iris, can be a challenge, and iris hooks can be a little bit better for those cases, especially with, that 5th hook, for example. So iris prolapse early, really consider a subincisional paracentesis and using that hook back there. And sometimes you get iris prolapse a little late. This is actually a pretty routine cataract. This is mine, but I would say the patient was valsalving quite a bit. And the wound was a little bit short, actually. And so what happened is, this is after the cataract's out, after the cortical cleanup is done. I'm actually about to go in to just put viscoelastic in order to put the lens in. And all of a sudden I have iris to that main wound. But what I don't want to do is go in with my cannula and damage the iris. I'm going to try a little bit, but nope, it's coming out. So I'm not going to go in. I'm going to burp the viscoelastic because you don't want to overfill the anterior chamber. And then I'm going to go in through my paracentesis and just use the viscoelastic, this dispersive, to really sweep it in. And look, hey, it happened again. We're basically at the very end of the case. I ended up having some iris prolapse. But what I'm doing right now is I'm actually, there's iris coming out of that wound. The lens is in the bag. I mean, this case is done. There is nothing left to do. And what I'm going to do is I'm actually going to there use myostat. And I'm not even going to go into the wound. I'm just going to sprinkle a little myostat on some of that iris that's prolapsed. That's going to allow that pupil to come down just enough that iris pops right back into place. So for late iris prolapse, consider myostat actually, because in a case like this, I don't want to go back in with a dispersive. I don't really want to go back in at all, actually, with anything except for some intracameral antibiotic. And so for that iris prolapse, consider just dribbling some myostat outside the eye to get it in. So I hope these pupil pearls have been helpful. Every single pearl has come because I have gotten into a moment in time. And so hopefully you can not get into those moments and just use these tools right off the bat.
Oh, Sumitra, that's so great. I really appreciate all those videos for multiple reasons. I think one of the concepts that you're kind of touching on, is the eye hard or is the eye soft? When iris starts to prolapse, that's the first question because different maneuvers will work well depending on that concept. So your myostat trick, I'm doing it tomorrow. I'm doing it tomorrow. I'm like, give me floppy iris. I love it. But that's only going to work if the eye's soft,
Well,
right?
and let's start with that case then. So
Yeah.
case number three, like when, one of the biggest things, as you mentioned, Sumitra, is once you have iris that comes out of a wound, which usually is the temporal wound. I mean, it can come out of a paracentesis when the eye has a really floppy iris, even when the eye is normotensive. But once the iris comes out, it just wants to continually come out, even if the pressure isn't high. But if it does have that tendency to come out, the first and most important thing to do, obviously, is to come through, as you demonstrated, through the opposite wounds, through a paracentesis. Make sure that you can check to get the eye to a normotensive state, because if you're not in a normotensive state, then it's going to be virtually impossible. Now, if the eye is really hard, then, we are dealing with either, especially at the end of a case, it's going to be where there's some level of congestion or uveal effusion or something to that effect. But if it is only where you've got BSS left in the eye and all you need to do is to get out of the case, and you're finished, that's at least your saving grace, where myostat works so well to try to get just that little bit of iris right back in there. And sometimes, yes, you can reposit a little dollop of um, dispersive cohesive right on top after you get like a softer eye and the myostat has started working. But that iris will still try to keep popping out unless you do get that iris to kind of constrict a bit.
The other thing that I was taught by Mike Snyder is that once the eye, if you just have a low pressure and it's still coming out of the wound because it's a short wound or floppy iris, you can tap at the roof of the incision and it'll tap its way back in. And that's also a really nice approach because even a little bit of fluid or myostat at that iris that's prolapsing will release pigment and you can still get transillumination defects just by it trying to come out. So staying away from your main incision and where it's prolapsing is also a good idea, or tapping at the roof of the incision. So talk to me about, how you had this knowledge that that tube and that synechia there was really holding everything in place. Like, what experiences have you had where you kind of may not want to, do all your synechiolisis like you did in the first case?
Yeah, I have had a case where I was a little overzealous about breaking the syndicate. There's something so amazing, satisfying about finding that little plane and then just going around and breaking the syndicate 360 with your cannula. But in that case, in the past, I started noticing that not only was the syndicate breaking, but the cataract was moving a little more posteriorly. And that was a traumatic case. But even in this uveitic case, it's gone through some surgeries, obviously. So sometimes the only thing holding that cataract in place, or maybe it's an IOL because you're doing an IOL exchange, the only thing holding it in place is actually that pupil. And so what I kind of have thought now is I'm only going to go a couple of clock hours at a time and in maybe two different directions at first. And that worked out well because my paras were so awkward. I couldn't have gone all the way around. But I really felt that in that case, it had been a while. One thing about inflammation is it creates scarring. Scarring can sometimes be helpful with zonulopathy because it sort of scars in some of the remaining zonules. And so the lens was relatively stable with the exception of that one small area. But yeah, just go, if you can't visualize the zonules, I just assume they're all really terrible. Maybe we're just all traumatized from all of our complex cataracts, but I just assume that all zonules are going to be weak unless I can visualize them or until the anterior capsulotomy is completed with no issues.
Sumitra, that is like the best mantra to live by, which is like if you've got a small pupil because it's sneaked down, like I only peel back what I need to safely do the surgery. Like in that first case where you already had that scarring from the tube down to the lens. Number one, I love that you did not attempt to do any kind of pupilloplasty because if you did, to close that defect, you would have gone between the pupil and created a potential space between the actual tube shunt unless you shortened it. So you would have been doing a tube shunt revision and the actual the lens capsule, even if there was space, but that could created an UGG syndrome because we don't know how posteriorly that actual tube shunt is positioned. So leaving that little gap, which is not the major issue, is, the best thing to do and leave that for another day. So that is huge. But in that area of the iridectomy from the creation of the prior iridectomy, you could see that the edge of the iris itself was sneaked down to the lens. And I love that you didn't peel that off to create intentionally this wide open, see to the equator of the lens. You allowed those pseudozonules to hold on, and then you used your strategic actual iris hooks radially around the areas where you wanted to open enough of an opening to have that 5 to 6 millimeter centered view for your cataract surgery. But that's so important. I mean, you weren't lysing everything out to 10, 11 millimeters because what's the purpose? I mean, we in a traumatic state, even though this is uveitic or not, I mean, there's iatrogenic changes from prior surgery. There's all sorts of things that we don't know the exact status of what's going on with the lens. And that's in any eye that's not a naive eye. So that's also another great pearl. It's peel back just enough because it can be hard enough to peel back. Sometimes you end up splitting the pigmented to the non-pigmented layer. You can have a lot of floppiness as it is. It can be quite challenging. There can be additional fibrosis and more shock value, underneath with what's going on with the anterior capsule and otherwise. So I love that you were very strategic about leaving the iris untouched, where it was kind of transected and sneaked right where along the edge of the prior iridectomy, juxtaposed to the actual tube shunt. And that's a great pearl.
Absolutely. The other thing, let's talk about sweeping the iris. Most people are just going to like shove viscoelastic in. Now you've taught them, please don't do that. If it's prolapsing, figure out, is the eye hard or is the eye soft? And then I've had to sometimes go in with a bimanual IA and like get the viscoelastic out because I couldn't control things. Then putting that iris hook underneath your main incision is great, but it's got to be a flexible iris hook. So the Grasshopper Alcon flexible iris hooks, because the MST ones I think are a bit too stiff to be able to handle the in and out maneuvers with the phaco. And then to not pull that subincisional one too tight. So I think those are some pearls there. I really think sweeping can be great, but you make sure that you're not sweeping at the iris root, because I don't know anyone who's done that before. Ask me how I know. You can create an iridodialysis. So really understanding how to sweep is important, and going gentle, more anterior at first, and then going a little bit more posterior, I think is really important, because I had one case where I was like, oh, I'm just going to sweep. And I swept and literally caused a huge iridodialysis. So talk about quicksand and Eureka. Um, Understand that when you went in, your eye was soft and you used also an injection of viscoelastic. Is that correct?
Yeah, I mean, I think when at all possible, and I've learned this just exactly for, past moments, where the viscoelastic basically should be used as your first line to move the iris. So you don't even have to touch the iris if you can kind of direct the viscoelastic with the cannula. So it's actually the viscoelastic kind of sweeping under the wound, bringing the iris in. And that really only works if just a little bit of iris is coming out. Obviously, if a whole bunch is coming out, you may need to go in. But like you said, just be very, very, very gentle. And just, your visualization should actually not be the tip of your cannula or the tip of a cyclodialysis spatula. It should actually be right where the iris root is. And if you see it moving too much, then you should stop. And, the pearl about the pressure, I mean, it's just something where I've come in when, and helped out other surgeons and, in our practice where they were like, there's just iris coming out everywhere. And the first thing I check is the pressure and it's really high. So I love that pearl just going in with the bimanual and just taking out, especially if it's a dispersive. You can't really burp out a dispersive like a cohesive, which is why, for IOL exchanges and these complex cases, I try to use a cohesive as much as possible
Ditto.
for moving things. The dispersive is just there and you'll need to go in and, that's okay. I usually tell them for these cases to, if I know I'm going to use a lot of viscoelastic, to keep the bimanual on first. But a case like this, I actually tell them to keep the bimanual on first and don't even set up the phaco yet because I'm probably going to use the bimanual first sometimes. Although in this case, we didn't need to. So that the bimanual technique is really good. And not everyone has a bimanual, on their tray, but, something keep in mind is to maybe have a disposable bimanual set or one reusable set just around, because going through two paras is so much easier than going through your main wound in a case where you have iris prolapse. So that is something to maybe keep in mind if you're going to do some of these cases to have on hand.
So those are like that's such a great point about everything that you've been mentioning. Now, to Nicole's point, sometimes that we go through all these kind of mental acrobatics and we've done this checklist, we've decompressed the eye, but the eye, you've gone in with your IA and the eye is still hard. You've gotten your dispersive out and you've done your due diligence, but the eye is still pretty hard. Like, what are you doing to then say, well, what should I do next? Like, the iris is still trying to prolapse out of your temporal wound. Are there any other miscellaneous things that you are doing to make sure to kind of say, okay, should I give up now? Or are there other things that you do to kind of, help the patient?
Well, the first thing, if iris keeps prolapsing is I check for a red reflex just because, that's our fear, right? That
Yeah.
we're having suprachoroidal hemorrhage. In a case where there's a pretty good red reflex, at least I feel pretty good. I see if the patient is comfortable. Sometimes a little check-in with anesthesia. Sometimes it's a little bit of loosening of the lid speculum. I feel there's some
Yes.
lid speculums that are a little tighter than others too. I think when they have deep brows, we just kind of shove it in there to try to get a good view of like the superior portion of the cornea. But it can be very tight on these patients. I've even had a case where the patient was a little bit uncomfortable, but also there was some iris prolapse. And I looked from the side, it was a trainee case, and it had gone to the point where the globe was actually kind of subluxing because, lifting
Yeah.
up on paras. And so be really conscientious of the fact that we have a lot of power over that globe. So checking the speculum is always important. And then I think sometimes you just have to be very honest with yourself. Like sometimes I'll make a short wound. And if there's iris coming out of that wound and I have done the subincisional trick and there's still iris coming out, it's okay to move, especially early in the case, to move to a different area if you absolutely need to. In a case, sometimes we have cases where the cornea is not a very good thickness in the periphery. And I kind of knew that going in, but I thought to myself, I can make a wound where I normally make my wound. And you realize it was kind of thinner in that area. I actually will put two partial thickness sutures, on each side of where the iris prolapse is, taking care not to get the iris prolapse. If you can get a lot of it inside and then tie them off. And then sometimes the iris then is easier to get in if you've got a couple of sutures, even if they're not in the center. And then you can always go back and put a nice pretty one in the center if you really want. But, those cases, especially peripheral corneal thinning, can be really hard. And so, in a case like that, you definitely want to move over. Or if the peripheral cornea is not that great, and you thought you could get away with a corneal incision, I've definitely sutured the corneal wound and just made a scleral tunnel and called it. Sometimes the cornea just was not made to do a larger than a 1 millimeter wound. And so it's okay to also convert from a clear corneal incision to a scleral tunnel if you absolutely need to.
Sure. Yeah. How about you, Nicole? Like, are there any other considerations? Like, what if, like sometimes the axial length actually makes a difference into my thought process?
Yeah, no, I think, ruling out a suprachoroidal, you ruled out that you overfilled, you ruled out your short incision. There's also, some irrigation misdirection, right? And
Yes.
irrigation
Yeah.
misdirection can happen in your zonulopathy cases. But you always want to rule out a suprachoroidal before you make those assumptions. And sometimes you can do a, limited vitrectomy, as long as you've looked at everything, to make sure there's no suprachoroidal. And that will allow you to equilibrate the anterior and posterior chamber. But I think we talked about this earlier, which is, sometimes you just need to close up and come back another time. If it's really a short eye, you're getting irrigation misdirection or an anterior effusion that you can't necessarily see. Sometimes just closing up, you put them in the post-op area for an hour, bring them back in, and you can kind of stabilize everything and get more of the viscoelastic out and have a much more stable situation. So, all of these things, iris prolapse, can be anything from, idiopathic or pharmacological mediated. It can be a short incision and iatrogenic in that case, or it can be a suprachoroidal, or it can be irrigation misdirection, or a short eye with these anterior effusions happening at the ciliary body. So you have to keep it all in check while you're addressing these issues.
So I've actually learned that, I had a uveitic kind of sneak down pupil, which I then did a little bit of sugar cane, with my cannula, to try to break and kind of enlarge. Like I was aiming it towards a dilator,
Mhm.
right? And then I put a little bit in, and then I did the going into that same area and gently sweeping, plus putting some viscoelastic. Guess who then created an iatrogenic misdirection? So then I created more kind of
More
positive
issues.
pressure,
Yeah,
yes, into the vitreous. So those are all things that we have to be mindful of, right? Because I've already have potential problems, and then I created more problems with so once I broke some synechia, I was having iris prolapse because I put more stuff into the posterior segment. So
right.
these are just things that we have to be mindful of with these kind of more complex cases, and just how much we start to inject into that kind of behind the iris space. But
Mhm.
absolutely. So what did I do? I mean, I went right under the iris and I tried to suck back, not into the vitreous, not going towards the vitreous, but trying to at least get some of that out. And then obviously that was manageable, but I recognize that if I had done any more and in shorter eyes, I've had to do a core vitrectomy, like 2.5 millimeters behind, but I had a view. In cases where I wouldn't have felt comfortable without a view, I've definitely just gone ahead and said, you know what, let's close up. I put a suture in,
Right.
let them sit out in the waiting room, put the Honan balloon on for 15 minutes, did a case or two, then brought them back in. And then under a block, just a peribulbar block, proceeded with the case, and it was a much more controlled situation. So
Right.
sometimes that can be a lifesaver. It's like just a comedy of errors or a combination of errors too.
Yeah, no, absolutely. And speaking of anesthesia, I think in that first case, I saw that eyeball moving
I
around.
know,
I
me
was like,
Oh, I
too.
know.
girl,
Yeah.
She's brave.
you have some big ovaries, girl. I
Yeah.
would do a subtenons always or a retrobulbar in that patient.
Like she had, so I always in these cases have a subtenons block ready.
Uh-huh.
Because she was looking all over the place. Actually, she spoke Spanish, and so I think part of it was like she needed a little bit of vocal local in the very
Hmm.
beginning. That was in Spanish,
Vocal
and
local.
not in
Yeah, that's
English.
so
People
good.
were like, "Look still," and like I was like, "No, no, no," and I said in Spanish instead. But yeah, she has
Solamente español.
exactly. Mira la luz. No, but at some point though, she did kind of relax a little bit. And so, that's a really good point. I had that
Yeah.
subtenons block ready for us, especially if I was going to have to do some more heroic things.
More.
The cataract portion actually did really well. The actual cataract came out really nicely. So once she fixated, she was fine.
Because you set yourself up for success, and that's what this is all
Yeah.
about.
This was incredible.
Yeah.
I mean, wasn't it? This was such a fun episode.
Yeah,
Dr.
absolutely.
Khandelwal, thank you so much.
Always fun being here with you guys.
And thank you to everyone for being part of this OQC Eureka Moments. We hope that this will certainly help with techniques on pupil management and speed the learning curve. And certainly through those cases where anyone runs into those kind of hairy moments with different types of pupil issues, that these gifted gems that Dr. Khandelwal has provided, it will help speed up and keep our patients safe and those cases smooth. So thank you so much, Dr. Khandelwal.
Great. And please remember to email quicksandchronicles@ascrs.org with any questions, feedback, comments, and don't forget to fill out that brief survey below. And remember, every time you think you have the eyeball figured out, it will humble you.
Yes. Oh my gosh, those words are so important. And we hope these collective experiences help develop that grace under pressure. So thank you, and we will see you next time.
Bye-bye, everyone.
Bye.
Bye.
Thanks for joining us for this episode of OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu. Hindsight really is 2020.